Hi everyone, and welcome to ABC's Anesthesia, and welcome again, Kim. Thanks so much for being on the channel with us. I'm going to give you another Viva. So we're just kind of running through the last final exam sittings, Viva questions, and really great to have you on. Now, you've had a bit of Viva practice in the last week or so. How's it gone?
It's going well. There's been a few semi-formal Viva nights at a few hospitals with trainees across Sydney.
Mhm.
But it's going well. Some things are coming together nicely. Sometimes I tumble into the weeds and get too specific too early and have to kind of dig your way through it. But I think every Viva brings you 1 or 2 or 3% better than the one before, and that's hopefully enough to get you over the line.
Yeah, and there's this thing about hopefully by the end of it, you're getting Vivas that you've kind of heard of before, like you're getting the repeats, and that's not cheating. That's just you're ready, and hopefully you get enough that you're getting that stage. Hey, you did mention you'll get different kinds of examiners. You'll get like the gentle, very conversational ones. Maybe they even look encouraging or seem encouraging versus someone who's far more straight-faced and direct. What do you think of that? What do you perceive? How would you handle that situation?
That's an interesting point. Just reflecting on the last week, there's certainly a Viva style or a question style from the examiner that I respond to quite well. Where it's more open-ended sort of questions, feeling like in a relaxed environment, even if the clinical situation is a little bit complicated, versus the stony-faced, very intense, very direct questioning style of other examiners. And I have found that in that latter scenario, I become a bit stony-faced and direct and intense, and my answers aren't the best answers. And I'm trying to work on just staying the same and that trying to maintain poise regardless of the examination style.
Yes.
And that's tricky.
That's exactly. And first of all, just to acknowledge that we're humans, so we mirror and respond in a human way to people. So that makes total sense. But also the insight that, hey, it actually doesn't matter. Like the manner of someone is actually irrelevant. The case is what matters. What is going on? Like obviously, you answer questions and try to pick up on cues if you can. But yeah, the examiners are going to be everywhere from stony face to gentle. And actually, I'd almost suggest that it's hard to know that they're stony face for everyone. If they're harsh to everyone, you may think you do better in gentle examiners, whatever, but you don't actually, and you don't know that. So it's a really tricky situation.
It's the one case I'm thinking about was the Viva was on an airway trauma, and it was a critically threatened airway, which obviously is complex. And the way the examiner was asking questions had this pressured and urgent nature to it. And I could feel that stress inside myself, like I was actually there. And then my answers aren't the best because you become task focused and maybe lose picture of the bigger, or maybe lose sight of the bigger picture. And I know that I could have performed better if I just took a breath and stepped back and thought, this is all a fake scenario. These are just words. What are the issues here? What are my solutions to the problems, and which one am I going to pick?
Yeah. And just to put it out there that urgent situations happen in real life, and obviously you'll have to manage that in an urgent fashion. Like saying a very slow response to anaphylaxis doesn't seem right, or a desaturation doesn't seem right. But also, you don't know if the examiner is hastening the pace because of the Viva. Like maybe
exactly
want to get through, but we don't know. So there's two games we're playing. We're playing the actual physiology game, the anesthesia clinical game, and we're playing the game of, hey, is this examiner trying to get me through quickly or not? And I've got to say, you won't know this. And every examiner is built differently. I know that some examiners mark, in a certain way and others in another way. And, depending on what they're trained on and how their experience, maybe they're a new examiner, who knows? But again, that's not the game we're playing. We're just here to give good clinical anesthesia. So hopefully it's not something to worry about.
It's all good. It's coming together.
Yeah, good. So I'll start just like before. I'm going to put up the stem, which is a very long stem. Answer stems can be incredibly long. For everyone listening, I'll read it out, but everyone watching on YouTube will be able to see this. So the question is, you are the anaesthetist in a multidisciplinary high-risk obstetric clinic at a tertiary referral hospital. You're reviewing a 29-year-old woman with rheumatic mitral stenosis who is 20 weeks pregnant with her first child, so G1P0. Medications are bisoprolol and enoxaparin at 80 milligrams subcut BD dose, previously on warfarin. Her echo done early in the days available for review. The question is, how would you assess the severity of her cardiac disease? So how would you assess the severity of her cardiac disease? And I'll give all the data here as well, which is far easier to see on YouTube, obviously. I'm just going to expand this. Transthoracic echo report, height 165, weight 80, BSA, so body surface area 1.9 square meters, heart rate 80 beats per minute, and rhythm is sinus. The left ventricle, so there's a number of different values, most relevant, ejection fraction 55%, normal being greater than 55%. Right ventricle mildly dilated, normal systolic function. LA, so left atrium, 70 mils per square meter, and normal is less than 35 mils per square meter. So 70 versus normal 35. Spontaneous echo contrast is the comment. Right atrium 35 mils per square meter, normal is less than 27. Aortic valve looks pretty normal. Mitral valve, thickened leaflets, doming of the anterior leaflet, restriction of the posterior leaflet, mean gradient 9 millimeters mercury, that's 9 millimeters mercury, and mitral valve area 1.5 square centimeters. Tricuspid normal morphology, estimated pulmonary artery systolic pressure is 40 millimeters mercury. Whew, I was tired just reading that out. Take whatever time you need, and everyone else pause the video here to have a think about how you want to assess the severity. Yeah, good. So, candidate, do you understand the question?
Yeah.
Fantastic. How would you assess the severity of her disease?
Looking over the entire clinical picture, this is a high-risk pregnancy. I'm really concerned about this lady. She's anticoagulated. She has at least moderate severity mitral stenosis from the echocardiogram. Puts her at a class 3 modified WHO. As such, the peripartum planning must be done with some degree of caution. It's got to be, and I'm going to say this from the outset, it needs to be done within a multidisciplinary team manner with ourselves, obstetrics, ICU, cardiology, neonatology. But to answer the question about severity, I'm going to do a history examination and look at some investigations. On history, I'd like to know what her functional capacity is. I'm going to determine that via a New York Heart Association score. I'd like to know what her current symptoms are. They may be dyspnea, dyspnea, palpitations, chest pain, presyncope even. I'd like to know how those symptoms may have changed over the course of her pregnancy. I want to know when she was diagnosed, how she was diagnosed, her progression over time, even before pregnancy, and what the underlying etiology may be. This might be something like rheumatic heart disease. I need to know about any complications. In this setting, this might be heart failure, arrhythmias like atrial fibrillation or pulmonary hypertension. The echo doesn't suggest pulmonary hypertension, but I want to talk a bit about it. And I need to know about exacerbations of the disease. So has she had anything that requires admission to hospital, i.e. for intravenous diuretics, inotropic therapy, or cardioversion even? Now, I noticed that she's on bisoprolol and anticoagulation. That suggests that she is being managed by potentially a cardiologist. So I'd like to get those letters from the cardiologist and see what their impression of the disease is. In terms of examination, I'd like to know the baseline vital stats, baseline vital signs for this lady. I want to know if she looks well or unwell from the end of the bed. We're going to do a targeted cardiovascular examination, and I'm particularly looking for left ventricular disorder and right ventricular disorder. Peripherally, we're feeling the pulse. Is she in a sinus rhythm or an irregular rhythm? In the chest, do we have left ventricular displaced apex beats? Do we have a right ventricular heave? Do we have peripheral edema, an elevated JVP, ascites, hepatomegaly? I'm going to listen to the chest, and what I'm listening for is like the diastolic murmur of mitral stenosis, a third or a fourth heart sound, which might suggest some degree strain. And I'm going to listen to the lungs. I'm looking for added sounds might suggest pulmonary edema. Now, investigations, we've got an echocardiogram, that's fantastic. But in addition to that, I know this lady's pregnant, but a chest X-ray, single film will be useful. Does she have cardiomegaly or pulmonary edema? An ECG, I'm looking for atrial fibrillation, left ventricular hypertrophy, right ventricular strain, any signs of ischemia. Bloods, I'm assessing for anemia. It's going to be important in this setting. Does she have an end organ dysfunction in her renal function or her LFTs? What is her NT-proBNP at baseline? And I want to look at her coagulation profile. So with all this information, we can make an assessment about the severity of her disease. I think just from the information that's provided, it's at least moderate severity.
Okay, good. You mentioned no pulmonary hypertension. What would you need to see? What would you want to know to determine that?
So there'll be symptoms of,
Hmm.
fatigue.
How about echo findings?
Or echo findings, sure. So we could have tricuspid regurgitation.
Yep.
And the severity of that would be useful. A TAPSE demonstrates right ventricular function.
Yep.
We could look at the, I think it's the fractional shortening of the right ventricle, and all of these indices can suggest some degree of right ventricular dysfunction, which is a result of pulmonary hypertension. We could work out the RVSP. We got it.
So we got the PASP 40. So what do you make of that?
Look, it's not severe pulmonary hypertension.
Would you call it pulmonary hypertension?
No, I wouldn't. It's hard on a TCE to talk about pulmonary hypertension. We need a right heart catheter, really.
Sure.
But it looks like the pressures in the pulmonary system aren't extraordinarily elevated.
Yep.
But I am keeping in mind it's certainly not normal, which is about 30.
Yeah, good. So in the context of mitral stenosis and the fact that she's got this evolving pathology, I think let's call it mild pulmonary hypertension at worst, maybe. What do you think of the term? So you mentioned on examination findings LVH. What was the relevance of that?
So she's got a stenotic disorder. So the on the left side of the heart.
Well, why LVH if it's a mitral stenosis? Or was that? Do you mean something else?
It's possible I mixed up my terminology there. It's the left atrium that's really struggling into the left ventricle. This is not aortic stenosis, which would be a more typical picture for left ventricular hypertrophy.
Yeah, great.
So I'll pay that.
Yeah, that's fine. Now, what do you make of on the echo, they have this term spontaneous echo contrast. What do you make of that?
To be honest, I saw that and didn't know what that meant, if I'm honest.
That's right. Now, tell me why you mentioned that, you noticed that the patient is on enoxaparin, ADBD, is obviously, thrombin, for a high thromboembolic risk. What are the reasons why this patient might be at high thromboembolic risk?
The two big reasons I can think of is the first, she's got a dilated left atrium on that echocardiogram. That's going to be a risk factor for atrial fibrillation and therefore clot formation. Mm-hmm. Secondly, she's pregnant. So she has an underlying thrombophilic condition. Mm-hmm. So she is predisposed to making clots at baseline. And in addition to that, she has got a left atrium, which might not be the healthiest left atrium.
That's great. So, I completely agree with you. Is any other risk factor that's not necessarily that she has, but she could have? That could be...
Other risk factors would be, obesity, underlying thrombophilias, like,
For her?
For her. Have I missed something?
No, it's very trivial, but something that she could maybe have.
I don't know if I would pick it.
It's trivial, so we're
okay.
Proceed with that anyway. Okay, good. So, what are the anesthetic implications as this pregnancy advances?
Okay. So I'm going to take a step back and talk about the hemodynamic goals of mitral stenosis, right? Mm. So we know that these people need to be maintained with their preload, their afterload, positive contractility, sinus rhythm, low PVR. Many of the physiological changes of pregnancy, which are progressive, are antithetical to those goals. So we have fluid overload state. That's not preload. That's not a euvolemic state. We have an increase in the heart rate by, I think it's about 20% from my part 1 knowledge. We have a reduction in the systemic vascular resistance by maybe 10% from my part 1 knowledge. So that's not in keeping with our goals. Mm-hmm. In addition, you've got this gravid uterus pushing up in the lungs. You lose your FRC. Remember from the U-shaped curve from part 1 that the pulmonary vascular resistance is not going to be optimized. Mm. So as her pregnancy progresses into the 3rd trimester, I would not be surprised if she has some degree of deterioration. And as a team, including us, the obstetricians, the cardiologist teams, we would be mindful to be monitoring her, monthly or bi-monthly as she approaches her gender.
What does this then increase the risk of?
It increases the risk of just cardiovascular deterioration.
Causing what?
Cardiac arrest, death, fluid loss.
Before that? Leading pathologies up to her?
Leading pathologies up to that. So hypoxemia, hypotension, arrhythmias. These things.
Which arrhythmias?
Atrial fibrillation would be a typical one, a supraventricular tachycardia, non-sustained VT. All of these are possible.
Yeah, good. How would you plan neuraxial, labor analgesia for this anticoagulated patient?
She would do good with an epidural. I would be very much encouraged to be and motivate her towards an epidural. The issue here is she's anticoagulated. So there needs to be a planning pathway there. So in theory, labor could be done by an induction of labor with a booked admission to hospital, ceasing her enoxaparin upon admission to hospital and starting on intravenous heparin. And then 6 hours before planned neuraxial intervention, cessation of that heparin. And in that setting, we have washed out the enoxaparin, we've kept her anticoagulated for that period of time, and then we've allowed enough time for the washout of the heparin so we can instrument her back safely.
Great. Six hours for heparin. What was the time frame for your enoxaparin?
Yeah, so she's on, let me remind myself, she's on
80 subcut.
BD. Yeah, so she's on a therapeutic dose, so 24 hours.
Yeah, good. Yeah. Okay, so what kind of analgesia, what kind of solutions would you be using for this?
In a neuraxial?
Yeah.
Yeah, it's going to be a slow rising block. Right. So I'd establish the block with something very mild, 0.1% ropivacaine, 1 ml at a time. Take my time with it. We're not in a rush. It's an induced labor. Slowly establish a block, to T6 over however long it takes. And then I'd run her of like a PIEB sort of formation with maybe 0.1% again.
PIEB?
Yeah, so programmed intermittent epidural bolus.
Oh, sure, yep. What other things around would you try to be managing at this point?
Yeah, so labor is going to be difficult for her. She might be dehydrated, tachycardic, the valve salvering and pushing are not optimal. So she needs a big drip and she needs to be fluid loaded. I would like her to have an arterial line.
Yep.
I would like a really good midwife. And I think if it's possible, I would like her to actually labor not in the labor ward. HGU would be a setting that I think would be the best for her because she is in
let's say you've got all of those things. So you've got the outline, you've got experienced staff, multidisciplinary team managing her. You've got the HDU obstetric setting as well. Now, at 32 weeks gestation, she presents in labor with fetal distress. So she's 32 weeks now. This is 12 weeks after that initial presentation. She had her enoxaparin dose 8 hours ago, and they've deemed that a cesarean section is required urgently. How would you conduct general anesthesia in this patient?
This is complex, and I would be a bit sweating on the phone when I get this phone call. So it's a very very concerning clinical picture. We have a premature fetus in distress. We've got established mitral stenosis, and we're still anticoagulated. We do require general anesthetic. My immediate sort of assessment is going to be an MDT. And he discussed with the obstetricians how urgently they need to get that baby out.
It's urgent, 30 minutes.
Yeah, urgently. Okay, we're going to identify assistants. So we're going to inform the intensive care. We're going to inform the neonatologist. I need them there in the room to resuscitate the baby. I need to put an arterial line in and ideally a central line for induction. She's going to have defibrillation pads on. I'm going to urgently discuss with hematology about whether we can reverse her enoxaparin. You can't, but Barriflex may be an option, but that's fine. I need a second anesthetist available, and ideally they have some degree of cardiac training. If they can place a toe intraoperatively, that would be fantastic.
You don't have that?
Yep, good.
You can do a basic ziphisternal view. Actually, sorry, a parasternal
view.
Yeah.
The big issues here from a general anesthetic in a pregnant patient still exist: the difficult airway, aspiration, cardiovascular collapse, postpartum hemorrhage. So this is going to be a general anesthetic. Endotracheal tube is a rapid sequence induction that is invasively monitored. She's going to be pre-oxygenated in the reverse Trendelenburg position.
If the central line, if suddenly the urgency increases and you're about to put the central line, but the surgeon goes, look, this baby needs to get out right now. And the central line will realistically take 15 minutes of flopping around.
It's not happening.
Okay, cool. Great. So you go ahead?
I'd proceed with that one.
Okay, cool.
Fluid load her. We've got to maintain euvolemia as we discussed. My induction drugs are going to be 300 micrograms of fentanyl, 75 milligrams of ketamine, 100 milligrams of rocuronium. We're going to use a video laryngoscope and a hyperangulated blade. We're going to have metaramnol running peripherally to maintain normal blood pressure for her. And she's going to be in the left uterine still. Once she's asleep and the surgeons are beginning, we're going to do a right ventricle protective ventilatory strategy. So maintaining normal oxygen, normal cardia, normal acid-base status, and minimizing the positive pressure. That's to minimize all PVR issues. And I'm going to maintain her on pseudofluoride at 0.8 to 1 Mac, titrated to a processed EEG.
Yep. And why sevoflurane?
In this setting, in a rush setting, in a sick patient, the fewer things that are attached to her, she's already got a lot of lines, the fewer things that are attached to her in my hands, the better. It simplifies the process. She has no reason not to have a sevoflurane-based anesthetic. There may be issues with tone of the uterus, but we can manage those things if required. It simplifies it in a situation where making a complex thing more simple for me is useful.
Okay. Baby's out. What are your steps then?
Okay. So baby's out. It's under a general anesthetic. It's going to need resuscitation. I have a neonatologist in the room because you told me I haven't. I've got one in the room.
Yep.
I'm going to allow them to manage the neonate because I have to manage this woman. I'm concerned about postpartum hemorrhage. An atonic uterus is going to be, possible.
Yep.
So we're going to give uterotonic agents, but the decision here and the dosing here is important. I'm going to give 1 unit of oxytocin over 1 minute, and then I'm going to start an infusion of 10 units per hour over 4 hours. So I'm not going to give a bolus.
Yep.
I'm avoiding carbocross. I'm avoiding ergo machine. They affect SVR and PVR too much and can make it quite unstable. Right. You can have some misoprostol 800 mics under the tongue.
Let's say, tone's pretty bad.
Yeah.
What do you do?
Tone's still pretty bad. I'm going to encourage the surgeons to see what they can do non-pharmacologically. So bundle rubs. Is there a possibility to do a suture? Is there a possibility to put a battery balloon? In addition, from my end, I might give another unit of oxytocin, but I'm giving these slowly. I do not want to drop her SVR.
Tone's still bad. You've done all those things?
Yeah. We've done all that I'm comfortable in doing pharmacologically. I'm going to be encouraging surgeons to say, I don't think that pharmacological options are going to be safe. What can you do surgically? And I understand we might be moving towards a pathway that leads to something that might resemble a hysterectomy.
Anything else before that?
Anything else before that? Well, sevoflurane. So maybe I change it to a TIVA-based anesthetic.
Yeah, good. Okay, so you do that, and things improve substantially. At what point would you give another agent when there's poor tone?
Yeah,
and you're balancing up this the hysterectomy.
Yeah.
Well,
this is uncharted territories for me. I've never been in this situation. I would admit that from the outset, but I have given people ergometry before. I've given people carbopros before, and they have marked hemodynamic changes that are drastic. I would not want to do it to this woman. I don't know what the outcome would be, and you could find yourself in a crisis, like a true cardiovascular collapse crisis. I don't think I'd be reaching for those agents in any setting. Because I don't know how safe they'll be, and I have a suspicion that I might cause a lot of harm.
Now, as you're doing all your management and appropriate management, she suddenly develops a tachycardia, and you see the heart rate go to 160. What do you do?
Okay. So this is actually a crisis because she will not tolerate that degree of tachycardia. So I'm going to press the arrest button because I need hands in the room. I'm going to inform the surgeons that we have an unstable woman. And I'm going to put a finger on the pulse to confirm that we are in this rate. When I look at my monitor, I want to see what the hemodynamics are. What's her blood pressure? What's her oxygenation? What's the ventilation? What's the capnogram doing? And what does the ECG look like? Do we have a broad complex tachycardia or a narrow complex tachycardia? Is there signs of ischemia, for instance? Looks
like an SVT AV nodal reentry tachycardia. Your end-tidal CO2 was 35. It's suddenly dropped to 28.
Yeah.
And oxygenation, ventilation's all normal as it was before. Your blood pressure you're running the aramine infusion with a blood pressure of 120 and it's dropped to 90.
Okay. This is a crisis. She will not tolerate this. I'm going to optimize 100% FiO2 and I'm going to cardiovertislating. We've got pads on.
How do you do that?
So we've got the pads on already. I'm going to inform the surgeons that whatever you're doing right now, you need to give me 30 seconds because I need to get her out of this rhythm. So I need everyone to step away from the bed.
Mhm.
We're going to be using a defibrillator like the Life Pack. We're going to put it on a synced mode.
Mhm.
I'll be honest, I can't remember what the dose is for SVT. It might be like 1 joule per kilogram. So let's put 100 on.
Mhm.
And I'm going to run the algorithm to assure safe delivery of electricity to this
You
patient.
do that, and you deliver a safe shock. It doesn't work. What do you do?
Right. I'm happy to give 2 more shocks. And I think that would be what I would do. And at the same time, I'm asking someone else in the room, the second anaesthetist, to draw up adenosine.
Yep. Anything else you'd do for the next 2 shocks?
You increase the dose. Yeah. So I'd go from 100 to 150 to 200.
Yeah, okay. Any benefit of just going straight to 200?
There probably is a benefit. Now that I think about it, she's under a general anesthetic. She's not feeling this. More electricity presumably is more effective. So look, I will get on board. Let's just go to 200.
Okay, good. How many shocks would you give total? You mentioned 3. Would you give 4?
No, I think 3 would be the number I give before I start to optimize any underlying physiology that I can to try and increase the efficacy of the shock. Every shock is causing some degree of harm to the myocardium. Mm-hmm. It's stunning it a little bit. It might damage myocytes. And
sure.
Yeah.
Now, look, the shock does work, let's say, but if it didn't work, what are all the other interventions you can do to treat SVT?
Yeah. So non-pharmacologically, a Valsalva maneuver can be used. We could do that on our anesthetic machine through the ventilator.
Yep.
I would be concerned in this lady Valsalva her.
Yeah.
You might find yourself very hypertensive.
Yeah, I wouldn't either. That would be scary. Keep going.
We can give adenosine, intravenously. So 6 milligram is the standard dose in an adult. If that doesn't work, we increase it to 12 milligrams. I think it's 12 milligrams the third time.
Mm-hmm.
And if we're at this stage and we still remain in an SVT, I'm going to be taking the arterial blood gas, finding out what her electrolytes are, making sure that we've optimized blood pressure, oxygenation, ventilation, fluid, and I'm going to be speaking to the cardiologist saying, I need your help.
Any other agents you could use for SVT?
I want to say amiodarone. I've never been in a situation where I've used it in this setting.
That's fair. Anything else?
I don't know.
Good. Let's say you sort out everything. You've reverted her. You didn't have to give any of those other medications. And the SVT was reverted. The baby delivered safely, and patients in recovery, babies in recovery as well. You've got your outline, you're monitoring and everything. And the mother suddenly desaturates to 85% on 10 liters of oxygen by the Hudson mask on the face.
Okay.
What do you do with that?
All right. So just to paint again, we've extubated this lady, presumably.
Yeah, we extubated you.
Yep. Okay, so I'm concerned. 85% in a patient without a secure airway or without being ventilated is concerning. I'm going to call for help again because this is a complex patient. She's not going to tolerate hypoxemia. I'm going to confirm the reading on the pulse oximeter.
Yep.
I'm going to assess all her vital signs, blood pressure, heart rate. I'm going to increase the degree of oxygenation that she gets. Yep. So Hudson mask, let's change it to a non-rebreather of 15 liters flow.
She's in sinus rhythm at 130, blood pressure is 140, and she's awake and obviously pretty hard breathing.
Yeah, so this is where, does she have a patent airway, those sorts of things. So if she's got a patent airway, she's got normal neuromuscular function. She's mentating well. It's just a B issue. There's a lot of things that could have caused this. She's had a few shocks. Have I given her a pneumothorax while she had the endotracheal tubing? Has she pushed off a pulmonary embolus from a DVT that was there?
Mm-hmm.
Has she had an amniotic fluid embolus? Mm-hmm. She went into SVT as she got acute pulmonary edema. So these are all my differentials. So I'm going to get my stethoscope out, auscultate the lungs, get the ultrasound probe out, look at the lungs and looking for a pneumothorax or acute pulmonary edema. We're going to take an arterial blood gas and send that off. We're going to get an ECG, see if there's anything funny happening there, and I'm going to get a chest X-ray to be brought to the room.
Beautiful. You see this, so everyone on YouTube, you'll be able to see it. But Kim, I'll get you to describe this chest X-ray for everyone listening, and maybe they can come up with a diagnosis with you. What's going on here?
So this shows pretty florid acute pulmonary edema. We've got bilateral infiltrates in both lung fields. There's upper lobe diversion.
Okay, that's the correct diagnosis. What do you do?
Okay, so she needs the management for acute pulmonary edema. This will be done in a high dependency unit for this lady. So oxygenation, 15 liters via non-rebreather. I'm going to position her bolt upright. I am going to, I'll actually go back. I'm going to change her non-rebreather to a non-invasive ventilator device. Yeah, so BiPAP. And I'm going to slowly titrate the pressures because, again, positive pressure in her can be challenging. Intravenous diuresis would be useful, but again, I need to be careful here. So I'd start slow with 20 milligrams of IV furosemide. If she's oxygenating at 85%, I would like to bring that up to 90, 91, 92 at a minimum. I don't want to rush the management of her pulmonary edema because if we are aggressive with positive pressure and diuresis, we could make her worse. And I want to get her into a monitored high dependency unit setting where, if required, if she doesn't improve from the setting, we can re-intubate her and deliver like quite invasive therapies for her to manage the situation. She would be a candidate for VV ECMO if required in this setting, but hopefully we can clear those lungs of fluid without, that kind of measure.
Any other medications you could get?
To improve her work of breathing, a low dose of an opioid could be useful. But I don't know if I've landed on what you want.
No, good. Hey, we'll end the Viva there.
Thanks for hearing.
Hey, how that feel?
Yeah, that was pretty hard.
No, you did really well. You got like pretty much all the points I wanted. The other questions I'm asking is more for the viewers and also just for the learning process of all the different options that might be there as well. But the important thing is, from this point, you gave me the critical things that would, make me, this patient survive. So, yes, thanks very much for watching and listening. So at this point, I'll say goodbye to the YouTube audience, and I'm going to give some feedback in more detail, which is on the final exam course, which you can see the link for at the end of this. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.